You all know I'm a big believer in taking care of our health from the inside out, and that absolutely includes our teeth. That's why I'm excited to share something I've been using and loving in my own home, the tooth powder and mouthwash from Dr. Michelle Jorgensen, founder of Total Care Dental and Living Well with Dr. Michelle. I have to tell you, I've tried so many natural oral care products over the years, but these are the ones I'm sticking with. The tooth powder gets my teeth feeling super clean and smooth, and the mouthwash has a really nice mouthfeel. I love that it has hydroxyapatite, which helps rebuild and strengthen my tooth enamel, and silver, which is really good for my oral microbiome. I also like that it's clean without any ingredients I need to worry about. The best part is my kids actually love it. They're obsessed with the orange flavor, and I have to hide the mouthwash so they don't just drink it. If you're looking for a great dentist-created option to take care of your teeth, I can't recommend Living Well with Dr. Michelle tooth powder and mouthwash enough. Give it a try. You and your teeth will thank me later. You can check it out at livingwellwithdrmichelle.com.
A lot of women don't know that heart disease is the number one killer of women, but it kills more women than all forms of cancer combined. So it's very important just for us to be aware of that, right?
Welcome back to another episode of Uplift for Her. I'm your host, Dr. Mallory Craycroft, and today we are digging into the nitty-gritty of heart health and what we can really do to prevent a heart attack before it ever happens. We are meeting with Dr. Tracy Paeschke. She is an integrative cardiologist. She feels so strongly about treating the whole person and not just waiting and treating women after they've had a heart attack, but really going backwards and being able to treat women before they ever get the heart attack to begin with, which of course is what all of us want. We'd really like to prevent having the crisis if we don't need to. Dr. Tracy Paeschke is a board-certified cardiologist and health coach with over 26 years of experience helping people prevent and reverse heart disease. She has shifted her own practice from traditional treatment models to more of a proactive, preventative, and integrative care model. She uses advanced lab testing, wearable technology, cutting-edge cardiac imaging, and she is going to tell us about all of that and more. I know there are so many questions that come up about LDL cholesterol and what tests should I have and what do I do about it. And if you know that you have high blood pressure or you know that you have high cholesterol, you do not want to miss this conversation.
And most people who have a heart attack, they don't have a severe blockage that caused their heart attack. They have a mild blockage, a soft plaque that became inflamed and unstable and ruptured and caused their acute event, like a volcano rupture.
Well, welcome on, Dr. Tracy. Thank you so much for taking the time to be with us. This is such an important conversation, and it's a little bit difficult to find experts like yourself who have really this well-rounded understanding of cardiology. So thank you so much for being here.
Thank you. And it's Heart Month.
Oh, that's right. It is Heart Month
Yep.
when we're recording this. That's right. I think this will come out after that, but still, we're recording it in the right spirit. So
yes, that's right.
Yeah. Well, wonderful. Well, I want to start by just allowing our listeners to get to know you a little bit. Tell us a little bit about your journey as a cardiologist and ending up where you are now, which is as a functional medicine cardiologist, taking this whole person approach to heart health.
Yeah, so I've been a cardiologist for 27 years now, practicing in the usual settings, right? So you go see the cardiologist when you're having a problem, right? Or you're having a heart attack. So after you do that for a while, taking care of people when they have their heart attacks or their heart failure, their arrhythmias, you realize that there's a whole period of time, 20 to 30 years before people have those events where we could have maybe intervened a little better to help them prevent those events from happening in the first place. And so it's hard to talk about all the things that we need to talk about to address all those things in the traditional healthcare setting, right? So our healthcare system is really good at reactive medicine, right? Right. Responding when someone comes in with their heart attack, we rush them off to the cath lab and open their artery. And, they usually just stay in the hospital a day or two and then they're home and taking medicines. And then you see the cardiologist once a year for a checkup, right?
Yeah.
For maybe 15 or 30 minutes if you're lucky. That hardly gives us enough time to talk about all the pieces that are important for heart health. So the diet, the exercise, stress management, sleep, all the stuff, right? And so I decided to leave the traditional cardiology setting, and I have a practice where I do I don't take insurance in my practice, so it's a very sort of niche practice, helping people either avoid their first cardiac event, or if they've already had some sort of cardiac event, or they already have high blood pressure, how do we improve those risk factors and prevent second events? So that's what I do now.
Well, I love that. I think it's great you're doing what you're doing. I think in medicine, reactive medicine, it feels good as the doctor for a certain amount of time. I mean, you do get to have someone who is struggling and you get to help them and you get to help them
Hmm.
feel better. But in my experience, the longer you stay in medicine, the more you kind of look backwards and say, yeah, I'm so happy that I was able to help you in this time of distress. But man, I wish you never would have had to get in distress to begin with. And so
Right.
I think it's really wonderful what you're doing. It takes a really thorough understanding of the whole duration of the disease to really prevent the disease, so for people like me who don't fully have an expertise in cardiology, we can still do a lot of preventative work, but I think you have this lovely, lovely skill set to really help people. So I'm excited for myself and for our listeners to learn from you today. We've talked before about heart disease being the number one killer of women and men, I think. And so it's a really big deal. This is a really big deal we're talking about. And not just the killer, but if you start adding in all of the other problems that come from heart disease, high blood pressure, you think strokes, dementia, even milder symptoms, just like not feeling good, heart
Right.
disease becomes a really big problem. So, what would you say? We'll just kind of start at the beginning and we won't spend too long at the beginning because we've covered this before. But what would you say are the biggest risk factors that if women already have should raise kind of flashing lights for them to be aware of in terms of risk factors for heart disease?
Yeah, so, and that is an important point because a lot of women don't know that heart disease is the number one killer of women, but it
Yeah.
kills more women than all forms of cancer combined.
Yep.
So
Yeah.
it's very important just for us to be aware of that, right?
Yeah. Yeah.
Again, there are different levels of prevention, right? So if someone already has high blood pressure or diabetes, metabolic syndrome, these are risk factors for heart disease. After women go through menopause, we tend to gain weight in our belly around
Hmm.
the abdomen, and that's called visceral fat. And that fat is more inflammatory and leads to all sorts of problems with insulin resistance and blood sugar regulation, and that increases our risk of cardiovascular disease. But then again, we want to think about what we call now primordial prevention. So, how do we even prevent those things, right? How do we not get high blood pressure? So, even stepping it back, right?
Hmm.
How do we not get any chronic diseases?
Hmm.
That's the goal.
That sounds great.
Um, yeah, right. Not just to not have a heart attack, but how do we prevent diabetes and metabolic syndrome and high blood pressure and obesity and all the things that are risk factors for heart disease? It's interesting, like if you go on the American Heart Association's website, that they talk a lot about that. Control your blood pressure and
Hmm.
make sure your cholesterol's low and control your diabetes. But they don't talk a lot about how to not get that stuff in the first place. I try to get people to think about it from the very beginning. Because not only is heart disease the number one killer of men and women, but chronic diseases in this country are astronomical. How do we not only increase our lifespan, but our health span, right?
Hmm.
How do we stay healthy as we age and avoid chronic diseases like diabetes, high blood pressure, metabolic syndrome, and heart disease? So
Yeah.
that's the key, I think.
Well, I think that is the key, and I want to hear what you have to say about that. Maybe let's just start with high blood pressure because high blood pressure it's so common and we see
Mhm.
it all the time and I think it's so common that it's really easy to kind of dismiss it like, "Oh yeah, my
Yeah.
mom has high blood pressure," or "Oh, my sister has high blood pressure." And we don't really think of it that much further. I think when we're diagnosed with high blood pressure, sometimes it gives us a moment of pause of like, "Oh, gosh, why is my body doing something wrong?" But what are the top things you want your patients to know? If that's kind of their main thing, we'll just kind of narrow it down for a minute. If they come in with high blood pressure, what are the main things we can do to get that blood pressure down?
We can follow a healthy diet. If you ask 10 cardiologists or 10 physicians what the best diet is, you'll get 10 different answers. But in general, we know that for cardiovascular disease, a plant based diet, is good for the heart, right?
Mm-hmm.
So it lowers cardiovascular risk and risk factors. A DASH diet is very good to help lower blood pressure. This has been studied in clinical trials. A Mediterranean diet. So all those diets have in common lots of fruits and vegetables, whole grains, less processed foods, less packaged foods, less refined sugars. So a more natural way of eating, like maybe we did 100 years ago, right?
Yeah.
And less sodium in the diet. For instance, the DASH diet has low sodium and higher potassium foods.
Mm-hmm.
So we know that that helps lower blood pressure. Some people are salt sensitive, not everybody, but some people, if they eat too much sodium, and again, in our standard American diet, there tends to be a lot of sodium, right? Especially
Mm-hmm.
in canned or processed foods. So you have to check that and be aware of how much sodium you're eating throughout the day and try to lower that. And we know that blood pressure goes down as your weight goes down. So if you're not at your ideal body weight, losing some weight can lower your blood pressure. Exercise helps lower blood pressure. Cutting out alcohol helps lower blood pressure, and it's good for your heart and your brain otherwise. And then sleep apnea. Often if people have undiagnosed, untreated sleep apnea, that can make their blood pressure go up during sleep and during the day. So that's always something to think about. The other issue is I don't think people know their blood pressure as well as they should. So I always tell people to know your numbers. Just like we know our weight and our height, we need to know our blood pressure, and we need to know our BMI, and we need to know our waist circumference, because again, that's where we tend to hold that visceral fat. And we need to know our hemoglobin A1C and our cholesterol. So all these things we just need to be more aware of, I think. So blood pressure should not be something that you get checked once a year at your doctor's office. I mean, these days, everybody can buy a pretty good blood pressure cuff at a retail store or Amazon for, $50 to $100. You can buy a good one. I tell people to check their blood pressure a couple times a week, different times of the day. We want to see what your blood pressure is doing all the time, because what I hear a lot is, oh, my blood pressure is just high because I'm in the doctor's office. Well,
Mm-hmm.
maybe,
I
or
don't
maybe it's
know.
high all the time and you don't know because you don't know. So I think that's important too.
I'm so glad you made that point because I actually had that thought just this morning as I was driving. I don't know why, but I was thinking, medicine has changed so much. It used to be, back in the prairie days, it was like the doctor on his horse that would come to see you when you were dying, and that was it. There was no preventative care. There was no maintenance of care. There was just like, do your best. And now we've evolved so far where people really can be empowered to take care of their own health. There's so much of this information that you can find out for yourself, even to the
Yep.
point of having labs drawn through just direct
Yep.
to consumer lab companies. I'm not necessarily advocating for that because you want to know what to do with that, but there are certain things that you can know for yourself, and blood pressure is super easy. And I think that most people should make that part of their home first aid kit. Like, you should have a blood pressure cuff at home at this point and be able to track that over time. Because it is, right? It's called the silent killer because it damages our bodies so much, but you don't ever have any symptoms. Most people don't have any
Right.
symptoms of it. So know your blood pressure, and then you can see if it's working too. So if you say like, "Ooh, well, maybe I do need to cut out alcohol," or maybe I got diagnosed with sleep apnea, now I'm going to wear my CPAP. Is it working? You want to know that
Right.
so you know if you need to take further steps.
Yep.
So if you have a woman who comes into your office and she says, I've been diagnosed with high blood pressure, and you go through lifestyle and she's exercising really quite consistently, she's eating well, and she's meditating daily, she's, kind of taking all of those basic steps. You might order a sleep study next. Is there anything else that you're thinking that from a test perspective that you would want to know if she's kind of checking those boxes otherwise?
Yeah, I mean, we often check electrolytes and kidney function and just make sure there's not something going on there. But typically, it's just sometimes high blood pressure runs in families.
Yeah.
Um, Sometimes people just have high blood pressure despite all the things they're doing that are otherwise healthy.
Yeah.
Now, it's not a normal part of aging. I mean, I don't want people to think that everybody gets high blood pressure. If you live to be 100, you're going to have That's actually not the case, right?
Yeah.
But a high percentage, I forget the percent, it's very high. In the
Mm-hmm.
United States, I think it's like 80% of people will have high blood pressure by the time they reach 80. Don't quote me on that, but
Mm-hmm.
the statistic is high. And again, I think it just has to do with life, modern life,
Well,
really.
and so much of the strain that our bodies are under due to culture, right, of
Yeah,
processed foods for our whole lives. Like you
right,
can eat healthy for some period of time and the body will reverse, but how long does it take? I think that's hard to
right.
say. Well,
Yeah.
so let's move on then from blood pressure. You were talking about risks of heart disease, and one of the risks that I had questions about is cholesterol. I think that
Mm.
cholesterol has a lot of confusion around it now. I think there are definitely, from the conventional medical perspective, I've heard doctors say sometimes, like, we should just put statins in the water so that everyone has a statin on board because the lower cholesterol, the better. And I think that's not necessarily the case. And I also think maybe it's just part of the conversation. I also think then on other sides of the conversation, you have people saying, doing carnivore diets or doing other diets and their LDL skyrockets and they say, it doesn't matter because I don't have any insulin resistance. So as long as my insulin resistance is fine, then it doesn't matter if my LDL is high. So tell us, what's the scoop on LDL cholesterol, which we call like our quote unquote bad cholesterol, right? We typically
Yeah.
want to see it less than 100 is what we're looking for when we go to the doctor and have our blood tested. But
Right.
where do we go from there?
The short answer, I think, is it's more nuanced than your cholesterol's high. Here, take Lipitor for the rest of your life.
Yeah.
For instance, when you get the standard lipid panel that you get at your normal doctor once a year, maybe, or every few years, contains total cholesterol, HDL, LDL, and triglycerides, right? And that's all we've checked for years. Really, that's the only thing that insurance will pay for preventive cardiology. Those your standard lipid panel.
Yeah.
Well, we know now that, for instance, the LDL number that you get on that standard lipid panel, it's a calculated value, right? It's a concentration. So it's the weight. It's not even directly measuring your LDL particles. So we know that if we do measure LDL particles or other cholesterol particles, that's called like an NMR usually, or a lipid profile, right? So that's directly measuring the particles because not all LDL is the same. We know that if you have big fluffy LDL particles, those are less likely to cause plaque than small dense LDL particles. So you can have a high total cholesterol and even a high LDL on that calculated value. But if they're all big fluffy particles, your risk is not the same as someone who has more small dense LDLs. So again, it's more nuanced. We know that ApoB is a more accurate measurement of the atherogenic bad cholesterol. In fact, some experts are saying we shouldn't even be checking LDL anymore. We should just check ApoB. There's a particle called LP little a. It's estimated that 1 in 5 people have elevated LP little a. LP little a is an independent risk factor for cardiovascular disease, meaning your cholesterol, LDL cholesterol, can be beautiful, but if your LP little a is high, you're still at risk for heart disease. And most people have never even had that one checked.
Mm-hmm.
So it's I think cholesterol is important. That's what makes the plaque,
Right.
right?
You can't have plaques
But
without cholesterol.
that's right. Indigenous people in the Amazon rainforest have LDL cholesterols in the 50s, and they don't get cardiovascular disease. Kids, toddlers, have LDLs of like 20 and 30. So lower is better on that. But the other piece that has been missing, I think, is the inflammation piece. So we know if we take people who've had a heart attack and we get their LDL down below 70, which is what guidelines recommend with a statin, but if they have an elevated CRP, if they have inflammation in their body that we don't address, they have significant residual risk, even with low LDLs. So that's the other big piece. And again, we've known for years that most people who have a heart attack have, quote, normal cholesterol levels. And most people who have a heart attack, they don't have a severe blockage that caused their heart attack. They have a mild blockage, a soft plaque that became inflamed and unstable and ruptured and caused their acute event, like a volcano rupturing. Release all that stuff into the bloodstream, which makes the blood clot, which is what causes a sudden heart attack. That's why that story that everybody's heard of, where somebody had a stress test and they passed their stress test and everything looked great, and then they had a big heart attack the next week. It's because a stress test looks for severe blockage that's impairing blood flow that causes changes on an EKG or a picture. Well, that's not what caused the heart attack. The heart attack was caused by that mild plaque that wouldn't be seen on those stress tests. So that's the big piece, I think, that we haven't been as good about addressing.
Okay, I want to come back to that because, yes, that is a big question. Let me see if I summarize this correctly. You correct me if I'm wrong. I think one of the difficulties with preventing heart disease is that it is multiple pieces to a puzzle that all fit together. So it's not like you can get any sort of picture from looking at one anything. You can look at insulin resistance alone and say you have increased risk of heart attack, but you really don't know that person until you look and see how much insulin resistance do you have? How is your blood pressure? How many vegetables are you eating in a day, right? Like how many plants are you eating in a day? How is your sleep? How is your stress? And then looking at the lab values, that LP little a you mentioned. So to my understanding, we check it once during life for women, once before menopause, once after menopause, because it can change a little bit. But that's a risk prognosticator. That helps us understand if you have a normal LP little a, then we're going to take the regular steps to make sure you're healthy. If you have a high LP little a, then that means you have to make up for that in tightening up all of the other elements so that your risk can go down as far as possible. So that is a really frustrating test because if it's high, it's kind of a bummer to tell patients like, hey, this test just means you're at higher risk and we can't lower that risk, but we can lower all of these other risks like insulin resistance, et cetera. So we can start building this picture now, looking at you as an individual and say, what is your baseline risk, maybe based on family, based on LP little a, and then start piecing together these other parts and say, overall, everything looks as good as it could. Your LDL is nice and low. Your HDL is nice and high. Your triglycerides are nice and low. Your LP little a is nice and low. Your blood pressure is great. Your energy is great. Great.
Yep.
You're doing great so far.
Yep.
And if not, then we work to kind of get those down. And for me, that just explains why functional medicine, I just think it's really difficult to go to your 10-minute annual exam with, for women, most of them are still going to their OBGYN for years. And there's no chance that most OBGYNs are going to have the type of training to have that kind of conversation, much less have the time to sit and really help you understand what your risk is. And I think that's a little bit how and that's no shade on my profession, right? Like it's not what we were trained to do, but women aren't really pushed in to do it with anyone else. And I think even family practice doctors, it takes a rare family practice doctor or internist who's, if you've never had a heart attack, to really sit down and go through these risk factors with you. It really takes some time to understand all of this. So anything you want to say on that part of just that baseline understanding?
No, I agree. And that's where the personalized medicine part comes in. Because, for instance, when someone comes to see me in my practice, we do the advanced lipid panel, sure, but we also check the ApoB and the LP little a and the NMR panel and the inflammatory markers and homocysteine and insulin levels and heat, right? Because yes, you're building a picture of someone's risk. And to build the picture, you need all the pieces.
Mm-hmm.
Because again, if your cholesterol looks great, but your LP little a is high and your CRP, the measure of inflammation, is high, you're at increased risk. So if you only get the standard lipid panel, it's only just a small piece of the puzzle.
Yes.
And that's why, we always see people that have a very strong family history of heart disease, and they say, oh, well, my doctor said my cholesterol is fine. I don't have anything to worry about. Well, that's just the tip of the iceberg, right?
That means you have one less thing to worry about.
Right. But we want to check everything so we know, because you're right. We have to have the data to be able to give an opinion to someone about, what to do about
Yeah.
those risk factors.
Before we move on, you mentioned advanced lipid panel, and the advanced lipid panel sounds super fancy, but it's not that far out of reach. It's not, when people hear that, I think they're like, ooh, that sounds expensive. It's not much. What are you checking
No.
on that?
So, of course, the standard lipid panel, ApoB, LP little a, LP plaque 2, right?
Mm-hmm. Mm-hmm.
Um,
LP, it's like
oxida-
L, little p,
yeah,
L, big A, little two, or two.
2. Yeah,
Yeah.
that's right. Myeloperoxidase, oxidized LDL, even fibrinogen and ferritin, those have to do with inflammation, right? So all these little markers, again, you can fill out your spreadsheet, and if all those things are low, or maybe just one is high, that's much different than someone who has high several things, right?
Exactly. And also, if you have LDL, your bad cholesterol is like okay. It's not terrible, not great. Maybe it's 120, 130. So, to put it in perspective, we want it to be less than 100 in screening, less than 70 after a heart attack. 190 loosely is kind of when you're thinking statin. That's the general ballpark. Hey friends, I have something really exciting to share. Uplift for Her will be at the upcoming Be Healthy Utah conference on April 11th and 12th. We'll have a booth where you can stop by and meet our team, and I'll also get to be one of their expert speakers on Saturday, April 12th. I would love to see you there and meet you in person. I've loved going to this conference. It's packed full of vendors, all focused on integrative health and wellness. There are always really great speakers, fun freebies, and lots of new brands to discover. And here's something special we're doing just for you. We're offering an exclusive discount on labs and lab reviews, but only for attendees at the show. Plus, stop by our booth and enter to win one of our amazing wellness gift baskets, each valued at over $200. Most of all, this is your chance to connect, learn, and have fun with a like-minded community. Mark your calendar, grab your tickets, and come say hi. We can't wait to see you at Be Healthy Utah at the Mountain America Expo Center in Sandy, Utah on April 11th and 12th. Tickets available on BeHealthyUtah.com. So if your cholesterol is like 120 to 140 and you do this advanced lipid panel and your inflammatory markers are terrible, then that's really helpful information, because if all you look at is the LDL, then your doctor is going to say, you know what, you should diet and exercise, see if you can get that LDL down. And that's going to be the end of the conversation. Literally, the entire sentence is the end of the conversation. But if you know that your LDL is like sort of okay, but you've got all these other inflammatory markers, maybe your LP little a is high, and you've got bad insulin resistance, and your CRP, that inflammatory marker, is high, and your myeloperoxidase, and if you have all these other things, that gives you the opportunity to then do something about it, to get the inflammation down, to get the cholesterol down. Even though it's just okay, you could still be at more risk than what it looks like on the surface. So I love the full picture. I think it's awesome.
The other part of the full picture that I think is important is some sort of imaging to see if you have plaque.
Perfect. So let's talk about this, because I think people are hearing about this more and more. This idea of coronary calcium score is one of them. And then tell us the other ways that we can really get an idea of all of those other labs, the LDL and the insulin resistance. That's all just telling us risk. That's telling us what could be going on in the body. When we image, we want to get an idea of what actually is already there. So explain to us the coronary calcium score and the other modalities, EKG2 or echo, or whatever else you use to really identify how is the actual blood vessel and plaque situation.
Right, because this is the key question. Mm-hmm. Do you have any plaque? Right. So the analogy would be like a mammogram, right? We get a mammogram to see if we have some abnormality in our breast tissue. Well, for cardiovascular screening, again, insurance doesn't pay for any routine cardiovascular screening beyond the standard lipid panel. So what we do in the traditional healthcare setting, how it's been, is we order the standard lipid panel, and then we get some risk calculator and we punch your numbers in, right? Mm-hmm. Well, that's fine, except those risk calculators are traditionally not tested on women. So most women that you put in that risk calculator will get a low risk. Mm-hmm. So we're missing a lot of women at risk. So again, doing the more advanced lipids and inflammatory markers will help us find some people. And then the big thing to find people who are at risk is to see if they have any plaque.
Mm-hmm.
So when I started in cardiology 20 some odd years ago, we didn't have really the technology to do this. But now we have several different options. So I think of them in sort of a stair step fashion, and this is how I explain it when I talk to people. So at the bottom to look for plaque, we have a CIMT, so a carotid ultrasound. So it's an easy test. You can usually get one for about $200 cash. They put a little jelly on your neck and take a picture of your carotid arteries with an ultrasound, no radiation exposure, takes about 10 minutes. And it looks for plaque or thickness in your carotid artery, which we know is associated with plaque in the heart arteries.
Mm-hmm.
So it's like a surrogate. Now, it's not directly looking at plaque in the heart artery, so that's a downside. But if that's the, if you want something, but you don't really want to go up in radiation exposure or cost, that's a good place to start. The next step up would be a calcium score. Right? So most people have heard of these. You can get these in most cities, either at the hospital or some imaging center for around $100. Often in February and October, they have specials because it's heart month. And so you put you on a table and you go under the scanner and it takes a picture of your heart, and then the computer calculates a calcium score. You don't get an IV. It's quick. You do get some radiation exposure, so it'll give you a score. Normal is 0, right? There shouldn't be any calcium in your coronary arteries. So normal is 0. And we know that as your score goes up, your risk goes up. So it starts to bump up around 100, and then it really starts to bump up when your score gets around 300 and 400. The downside of a calcium score is that it only looks at hard calcified plaque. So, for instance, if you're someone who has an elevated Lp(a), you are more likely to have soft plaque than hard plaque. So you could have a calcium score of 0 and still have lots of plaque because it's just not picking up your soft plaque.
Mm-hmm.
So the next step up is a CCTA. So that's a CT of the coronary arteries. So it's like a non-invasive heart cath, right? I used to do heart caths back in the day where we go up in your groin, or now they go in your wrist and they shoot dye to look for plaque. Well, this is a non-invasive way to look for plaque. You go under the scanner, they give you an IV with this one. They give you a contrast dye to light up your coronary arteries. And then they take a picture of your heart and they can reconstruct your heart and make this model, and they can look inside of the arteries for blockage, and they can tell a little bit about what kind of plaque it is. But if you really want to know what kind of plaque it is, you do the CCTA and then you send it off to Clearly.
Mm-hmm.
So Clearly is the AI analysis of the plaque.
And that's CLEERLY.
Yeah, and they give you beautiful pictures of your coronary arteries. So then not only do you know, if you have blockage, what percent of blockage it is, where it is, and then it breaks it down as to what kind of plaque it is, hard plaque, soft plaque, or inflamed plaque, which is the worst. So that's the greatest thing, right? Because then we take all those advanced lipids and inflammatory markers, and then we take your pictures and then talk about personalized assessment and recommendations. Yeah. That's how you really
know where you're at. So let me back up a little bit. So you talked about hard plaques or soft plaques, and the soft plaques are more concerning because they're more likely to rupture. They're also kind of younger plaques. Is that right? They're less
Correct.
Mature. One of the things that statin medications does is it calcifies it. It puts it makes those plaques get a hard coating on them, so they're less likely to rupture. So that's one of the benefits that we see with statins, and that's more what you're talking about for the coronary calcium score. What we see is calcified plaques, so you can kind of see where those plaques have already matured. Now, no plaque is what we're going for, but if there is any calcified plaque there, that is a sign that you have some process going on. If you can see with any of the others, is the CIMT, is it seeing calcified or soft? Can it tell the difference?
No, can't
It's
tell
just
the
looking
difference.
for plaque.
Yes.
Yeah, thickness of plaque.
Mm-hmm.
So after we get this view of do you have plaque, ideally the best version is telling us soft plaque, inflamed plaque, hard plaque. But with any of these, now we know, okay, I have some plaque there. Let's start with the easier scenario. The easier scenario is I don't have any plaque there. I don't see anything. My markers are all okay or not high. Anything you want to say about those people that they don't have plaque yet, but their numbers are not perfect?
Well, I still guide them to the pillars of lifestyle medicine. So, whole food plant-based diet, regular exercise, restorative sleep, avoiding risky substances, social
Mm-hmm.
connection, and stress management.
Yeah. Okay.
Because those pillars are good for good health in general, right? Because
Yeah.
if you do all those things, even if you don't have any plaque in your coronary arteries, if you follow the pillars of lifestyle medicine, it's going to your brain age well, your bones and muscles and your balance and decrease risk of certain cancers. So it's going to help you in other ways as well. So again, I still make that the foundation for good health.
Great. Okay, now let's take the more complicated scenario, which is you have someone with abnormal markers and then you have imaging that shows plaque. So
Yep.
we can't get rid of plaque that we know of currently, to my understanding. Is that correct?
A little. So soft plaque, you can actually regress soft plaque. Dr. Dean Ornish, the cardiologist, did those original studies back 30 years ago, where he did angiograms before and after he put people on a plant-based diet, stress management, and exercise. And he saw plaque regression. So we can see some plaque regression, soft plaque, and then, like you mentioned, converting it to hard plaque, again, because that's the more stable kind of plaque.
Yeah, let me back up a little bit then. So you have that scenario, labs abnormal, plaques present. Walk us through kind of your approach in that way. We've spoken about lifestyle, so I think that's obviously going to be the same lifestyle stuff. But you're going to turn the volume up, right? Like your
Correct.
diet, you really want to narrow in, and your movement and your sleep and evaluating for sleep apnea.
Yeah.
What else are you going to be doing as part of that evaluation to make sure that this person now at pretty high risk for a heart attack can decrease their risk?
A couple of things I always try to get people to do is some form of wearable.
Uh-huh.
I think wearable data is great because it helps them. Again, they've looked at this. People overestimate how much they're exercising, they underestimate how much they're eating, right? And wearables are great at tracking sleep. So to me, this is one of those falls under the know your numbers things,
Yep.
right? So some sort of wearable to track things and make sure you're getting things on target as much as you think you are. I try to get people to do a 2-week continuous glucose monitor to see how different foods affect their blood sugar. I talk about supplements with people, red yeast rice and a good multivitamin and B vitamins and vitamin D and omega-3, anti-inflammatory food. But sometimes people need prescription medicines. Again, though, it's not just the old, your cholesterol's high, here, take Lipitor for the rest of your life. Because a
Mm-hmm.
lot of people, that's hard. I mean, I wouldn't do that as a
I
patient
wouldn't want to.
myself,
Yeah.
right. So, but if I can show someone their clearly picture that has their artery laid out before them with significant plaque inside there, it really helps you see what's going on. And then if it's time to talk about prescription lipid lowering drugs, then you can see why I might be recommending that because you have this plaque and it's 30% and your LAD and it's soft plaque and it's a dangerous kind of plaque and your LDL is, or even more specifically, your ApoB is 120. Well, I want your ApoB to be less than 55. I actually go by European guidelines, even more stringent.
Mm-hmm.
Lower the better. And so, again, when you're looking at your own personalized data, it's easier for you to make health decisions. So then I talked to you about different lipid lowering prescription therapies. Statins, everybody knows about those. So there are injectable medications, PCSK9 inhibitors that get cholesterol really low. There's bempedoic acid, there's Zetia, there's some new ones, even coming out targeted directly to LP(a). So there's a lot of options. And sometimes we know that if we combine medications, sort of like sometimes we combine blood pressure medications to get a synergistic effect, if we combine a mid-dose statin and Zetia, often it works better to get LDL down with less side effects, right? Because you're not doing high-dose statin therapy. So there are a lot of options. Again, it's hard in the traditional system for your cardiologist to go over all those options because it takes time and it takes just sort of this back and forth. And so it's a lot easier to say, here, take your Lipitor. But there are options.
Yeah, I want to go down that road just a little bit more. Because I'm not a cardiologist, when I have someone who is at high risk for a heart attack, then I feel obligated to send them to a cardiologist while we're continuing to work on the lifestyle aspect of things. And I found some cardiologists have a lot of resistance to really anything other than a statin. So we might do advanced lipid testing and see that they should respond well to Zetia. And I think one of the frustrations is a lot of these patients will find that, nah, that's not going to work. That they're kind of just dismissed. And I think that this goes back to what you were saying is the more a patient can know their own numbers, they can say, well, but this came down, like this worked.
Right.
So
Yes.
I think that's really empowering I don't want patients to think they're in this alone. And I really dislike it when we as a medical community make it feel like the patients are against the conventional medical system. There are lots of doctors doing really wonderful things. So I don't want people to go in feeling like they're going to have to fight for good care. But at the same time, I want to empower people to know the more you know your numbers, the more you can advocate for yourself and say, look, I don't want to take a statin. What else can I do? But going back to what you were saying with all of the risk stratification is, if you already have a ton of plaque there and your numbers are bad, you may not want to skip the statin. I think sometimes from a patient perspective, we have this feeling kind of like you and I both said, like, I don't want to take that if I don't have to take it. And so I get that. I think that's where all of us want to be is I want to, and we both get patients coming in this way, right? Like, I want to heal myself naturally. I want to be as healthy as I can without medications. And I think that's a really good goal. But the bigger goal is to not have a heart attack. The bigger goal is to not die of a heart attack. And so for people to recognize where you're at, if you don't have any plaque and your numbers are like, okay, by all means, let's dig into lifestyle. Let's use natural methods to make you as healthy as possible. And at some point along the evolution of the disease, sometimes we get to use medications to help that process a little bit more. And I want to be clear about that nuance because I think it can feel really discouraging to patients if they have to be put on a medication, like they somehow failed or did something wrong. And the fact is there's lots of factors that go into this. And we are very lucky to have great medications and really great lifestyle measures and hopefully risk stratification and starting early enough that we don't develop this disease. Like we get all of these tools. But I don't want people to feel like failures or like they should reject the medications because medications are inherently bad, right?
Right. I think, as usual, the answer is probably somewhere in the middle, right?
Yeah.
I mean, there are people that don't want to change their lifestyle at all and just want a pill, right?
Yeah.
So there's that end of the spectrum. And then people who don't want any prescription medications at all. And I understand really all across the spectrum. Anyone who's been a physician for any amount of time has seen all that. But again, I think if you're working with someone who has time to get to know you, how you feel about these things, what your health goals are, that's where the beauty comes in, right?
Yeah, exactly. And see you in follow-up. I think that's the hardest part is if you can say like, can we retest my labs in 3 months? I'm really going to nail this down. I'm really going to do it. I think unless you are on the verge of having a heart attack, these images are terrible. Most of the time, doctors are going to say, okay, yeah, go give it a shot.
That's right.
We'll recheck, see where you're at. So I think, but it takes time. It takes time to then do the follow-up and do the repeat labs.
But I think that's a key point, though, because sometimes when you're in the system, someone will see a cardiologist or their primary care, even a nurse practitioner, and they'll make some slight change, but then not recheck things for like a year. Somebody needs to stay on top of that. And sure, we can start this medication or this supplement, or you eat a more plant-based diet and recheck in a couple months, not 12 months, right?
Yeah.
Because time just goes by quickly.
Yeah. And the good thing is that insurance is pretty good at paying for the basic cardiology labs. I also think like of the functional markers that we do, the advanced lipid ones are by far some of the least expensive. At least for me, I have pretty good pricing, but the LP little a and ApoB, they're not expensive tests. They're
Mm-mm.
not, they're quite simple.
Yeah. The other thing you were talking about, direct to consumer labs,
Yeah.
I think this is great actually,
Yeah.
because I see people all the time who say, I went to my primary care doctor. I heard somebody talk about LP little a and I asked them to check that and they said, no, I
They
don't
said
need
no.
that.
Mm-hmm.
But that's the old gatekeeping, paternalistic physician model, right?
Yeah. Mm-hmm.
I think back to what you were saying about being empowered about your health. When you go to Function Health and get that lab panel, or you go to Quest and order some labs that you heard about on this podcast, again, I get calls every week from somebody who had labs drawn on Function Health and their LP little a is sky high and
Yeah.
they had no idea. And maybe their primary care doctor doesn't know what to do with that information, or they're scared to even tell their primary care doctor because they went outside them to get labs, right? It's just kind of it's a weird system.
I totally agree with you. And being on the doctor side of it, I have seen these conversations among doctors who are like mad that their patients
Yeah,
got labs drawn somewhere else and now their labs are abnormal. And
yeah,
what's funny is a lot of the doctors will say, why did you draw it in the first place? You never would have known it was abnormal if you hadn't have
right.
drawn it. And to me, I'm like, well, who cares why they drew it? The good news is you
Yeah,
know it's wrong. So it's a
yeah,
really funny mentality. And in some, I don't want to, there's lots and lots of good doctors out there, but that mentality has never made sense to me of
yeah,
like, what do I do with this abnormal lab finding? And the response is, you never should have checked it. Like, well, we did, and it's abnormal. So how do I help this
right.
person? So there is unfortunately a lot of weird pushback from doctors. And I think
Yeah,
find a doctor who's willing to think outside the box and willing to
yeah,
go the extra mile. I think a lot of the reason why a lot of doctors say no is they'll just automatically say, like, insurance not going to cover it.
yeah.
And even if a patient says, then I'll pay for it out of pocket, the doctor doesn't want to be caught up in that loop. They don't want to
No,
get complained to and the cost is high and they don't know necessarily what to do with it. So, I mean, the ideal, I think, is finding a doctor who can order it and interpret it for you and help you just kind of put the whole situation together for you. But short of that, it does leave patients in kind of a weird spot where they can order the labs, but then who interprets it for them. So more just empathy for anyone listening who's experienced this, because it's kind of annoying.
yeah.
I think it'll stop. I think more and more there will be doctors who can kind of do this for you, but it's a weird zone right now. I'm
Hmm.
happy to do what I do, that I can just order the test and not make patients feel bad about it and move
Right,
on. Yeah.
right.
Okay, well, maybe as we're starting to wrap up here, tell us about the nature of just aging. You know, what if I already have this disease state? What if I've already had a heart attack versus, you know, I'm 20, I'm getting ready to have a baby and, you know, just found out my cholesterol was just barely above normal and I have a little bit of insulin resistance. What do you have to say about this, the duration of the disease and kind of how we approach this throughout our lives?
Yeah, right. I would say for people to remember that it's never too early and it's never too late to think about our health, right?
Mm-hmm.
And we know this that, they've studied people who can quit smoking when they're 80 and their health improves even if they stop when they're 80, right?
Mm-hmm.
And on the flip side, we know that children, especially now, kids are getting type 2 diabetes that we never used to see in kids. Their blood pressures are high. I mean, there's no telling where that's going to end up. Not good, obviously.
Mm-mm.
But it's never too early to follow these pillars of lifestyle medicine for good health. And then as we go through life, things change, right? So we know that women with high blood pressure or gestational diabetes or preeclampsia, those increase cardiovascular risk down the road. So just something to be aware of. We know that we age sort of in two big spurts, right?
Hmm.
Around 44 and around 60.
Hmm.
So those are great times to sort of reassess and look at what we're doing, get your wearable and see how things that you're doing are making a difference, positive or negative, and just sort of rethink your health I think it's always good to reassess, sort of like you
Mm-hmm.
reassess your finances, right?
Mm-hmm.
So once a year, sit down and then reassess your health. Do I need to, what should I work on this year,
Yeah.
right?
Yeah.
So always be thinking about it, not to where it's like a drag. Oh, I gotta exercise, and more of an empowering message, right? It's estimated that 80 to 90% of heart disease is avoidable through lifestyle modification. So that's a huge
That's
percentage, right?
huge.
That's a lot that we have under our control. So that's an empowering message, right? Not that you're destined to have a heart attack because your mom did, or heart disease runs in your family, or you have diabetes. Nope, we can improve those things, lower your risk, and you can live to be 100 in good health. That's
Yeah.
the goal.
I love that. And I just want to advocate for health coaching, actually. And I think you
Mhm.
offer this at your clinic as well, or some sort of coaching program you can tell us about. But just, a lot of people think they can't get started with this until they first see their doctor, right? They have to first find the functional medicine doctor and get all the tests and all of the things on the internet that say test, don't guess, right? Like, yeah, but also like find yourself a health coach and focus on those lifestyle pillars, right?
Yeah.
Food, sleep, movement, social connectedness, stress. What am I missing? Gut health,
Avoiding
environment.
risky substance. Yeah.
Yeah, like
Toxins.
those are
Hmm.
not medicine. Now, I and you as functional medicine doctors are so happy to help you talk through that. But you
Yep.
don't need a doctor for that. You need just
Mm-mm.
a health coach. You need a
Right.
well-educated health program that can help you get those things in place. Because you know what? After you have those lab tests, guess what we're going to tell you to do? That we're still going
Right.
to say, like, go get these health pillars under control. And so I love that idea of setting an alarm in your phone, maybe once a year on your birthday or something like that, where you kind of sit down and do a little inventory of how is my
Yep.
sleep, how is my movement, how is my food, not from a guilt standpoint, but like, do you know what? I could increase my vegetables, I could walk a little
Hmm.
more, I could, eat a little more protein, or eat more plants. So I think giving you, just like you just said, that opportunity to step up your game and know that it will make a difference, like a big difference. Not, I mean, you can still see a functional medicine doctor and we can kind of find these root causes, these other big things that kind of get stuck that we've got to get out of the way. But so much more than that is just the pillars, and just
Yeah.
working with someone who can help you get those lifestyles under control, and having a coach for accountability to just help you make those steps, because they're hard to
Yep.
do on your own. Anyway, side
Yep.
tangent, but I'm just a big
No.
fan.
Yeah. I agree.
Is there anything, as we're closing, that you'd like to say to just the women listening about cardiology and about heart health and heart disease prevention? Is there any final message that you either want to reiterate or that we've left out?
Again, just the awareness that it's the number one killer of women, right? And women tend to make healthcare decisions, and they tend to do the cooking and the purchasing. So buy healthy things, get rid of toxic chemicals when you can. I always tell people about the Yucca app. You
Yeah,
use the Yucca app.
yeah,
I
yeah,
love that, right? Scan everything and make
yeah.
sure things you bring in the house are healthy. They found microplastics in carotid plaque. I'm sure you saw that,
Mm-hmm.
and brain. So
Mm-hmm.
that's a huge problem. So there's a lot in modern life, right? There are a lot of things kind of pushing against us. But again, if we keep health top of mind and we think about it and we do small things, over time it adds up to big changes. It can be overwhelming if you
Yeah.
think about, oh, I've got to eat better, exercise, blah blah blah. Don't think about it like that, right? What's one thing I can do this week,
Yep.
right? So
Yep.
just start small, make small changes, leads to big changes. And then lastly, I would say on my website, I offer a free health consultation. So, like, if someone doesn't really know how I could help them, and they just want to run something by me, you can go on my website and schedule that, and I'd be happy to talk to you.
Oh, that's wonderful. Then that's my next question: is how do people find you? Where are you located? Your website name, etc.
Yeah, that's the best place, probably my website. It's www.hearthealth.care.
Oh, nice.
Yep. Yeah. So there's some free resources on there, and that link for the health consultation.
And do you have a wellness program, or you have something on there that kind of gets people
Yeah.
started?
I have I call it Heart Health Foundations. So
Yeah.
again, it's Foundations for Good Health.
And that's
Yeah.
for people only in Colorado, or who is that
No,
for?
that's health coaching with me.
Yeah.
So anybody can do that.
Yeah.
Yeah.
That's
And
awesome.
I'm licensed for medical stuff. I'm licensed in 7 states, so I can help people in various ways. So I just tell people to reach out to me, and we can figure out how I can help them.
And are you thinking you see people who have been diagnosed with high cholesterol or high blood pressure, or who have had a heart attack, or anywhere along the way?
Yep, anywhere along the way.
Yeah.
From people who maybe have a family history, or they just want to get a clearly test and I can help them navigate that, to people who had a heart attack when they were 50 and don't want another one.
Yeah. Yeah.
Yeah.
Well, thank you so much for being here. You are a vast resource of information, so we are really grateful for this. This was really helpful.
Thank you for having me.
Thank you so much for tuning in to today's episode. A huge thank you to our guest for sharing their insights and time with us. We are grateful for the incredible support from our sponsors and to all of you listening. We couldn't do this without you. If you enjoyed this episode, please consider subscribing on your favorite platform. You can find us on our website, upliftforher.com, YouTube, Apple Podcasts, Spotify, or wherever you love to listen. And if you found value here today, please share this episode with someone who would benefit from it. Leave us a comment or give us a review. It really helps us reach more listeners like you. Thank you for being part of our community. Stay tuned for our next episode. Lastly, this information is for educational purposes only and not intended to be medical advice.